Hello everyone and welcome to another session in the HC3 course. In today's lesson, we will be continuing our discussion on the concept of reproduction. This session will introduce you to fetal assessments during labor. But before we proceed, I want to take the time to remind you of the learning outcomes for this session. At the end of this session, you, the learner, should be able to explain the baseline fetal heart rate and evaluate periodic changes. Describe nursing measures that can be used to maintain fetal heart rate patterns within normal limits. You should also be able to differentiate among the nursing interventions used to manage specific fetal heart rate patterns, including tachycardia, bradycardia, absent or minimal variability, and late and variable decelerations. Now let's get into our topic. Electronic fetal monitoring is a useful tool for visualizing fetal heart rate patterns on the monitor or screen. In some circumstances, it can also be printed and the traces can be reviewed if there is not the presence of a monitor or a link between the device and a monitor. It was first used in the 1970s and its intended purpose was to try and decrease the number of cases for cerebral palsy. However, this has been found not to have helped because the rate has not changed since then. But it has become a very useful tool in monitoring for birth complications, especially complications related to the fetus. The primary mode of intrapartum assessment in the United States is the electronic fetal monitoring now. The fetus undergoes many physiological stresses during labor, and the greatest risk to the fetus during labor is the lack of or decreased oxygen supply. Abnormal fetal heart rate patterns are those associated with fetal hypoxemia. So if the fetus does not get adequate oxygen, then as we have learned perfusion, there are some body mechanisms that go into effect to try and help. And this may include an increase in the heart rate. That's why we see tachycardia. And this is as a result of the hypoxemia. So to ensure the well-being of the fetus and the mother, nurses frequently monitor the fetal status as part of the care during labor. Fetal oxygenation may be impaired when there is a reduction in blood flow through the maternal vessels as a result of hypertension or hypotension, and also a reduction of oxygen content in maternal blood as a result of bleeding or severe anemia can result in a decrease in the amount of oxygen that the fetus is getting or that is available to the fetus. An alteration in fetal circulation with compression of the umbilical cord resulting from a cord prolapse or prolonged contractions or contractions that are very close together preventing the uterus from relaxing can also decrease the amount of oxygen that is available to the fetus. This can also result from the separation of the placenta from the uterine wall, as in placenta previa or abruption that we talked about in our earlier sessions. So what does the reduction do? A reduction in blood flow to the intervillous space in placenta normally precipitated by excessive oxytocin infusion or destruction of blood cells or blood vessels in the placenta due to maternal conditions such as hypertension or diabetes can also reduce the amount of oxygen to the fetus. What are the components of fetal monitoring? The components of fetal monitoring include assessing uterine activity and the fetal heart rate. So we are going to talk about the normal uterine activity during labor, which includes the frequency of contractions, the duration of contractions, the strength of contractions, because as we noticed during labor, we need the power to be able to push this baby out. So the contractions has to be at a certain level to be able to push the baby out. We also will have to consider the resting tone. So does the uterus have enough time to relax to allow for perfusion to the fetus? And then how much time is the uterus getting to relax? All this is going to affect the well-being of the fetus in the uterine environment. Normal heart rate for the fetus ranges from 110 to 160 beats per minute. It is higher than 160 only in preterm infants. This is why it is very important to know or estimate the gestational age of the fetus and know whether it is term or not, so that we can interpret the fetal heart rate accurately. The goal of intrapartum fetal monitoring is to identify or differentiate between normal and abnormal patterns and to intervene promptly to prevent fetal hypoxia and subsequent complications, as I've already talked about. So now that we understand why fetal monitoring is an important aspect of nursing care during labor, let's consider some monitoring techniques or what some of the nursing roles are during the fetal assessment or monitoring. There are various types of techniques used in monitoring the fetus during labor. Although the ideal method for fetal monitoring during labor is still debatable, there are a couple of techniques that we can use, and one of them is intermittent auscultation. With this technique, the nurse listens to the fetal heart sounds at periodic intervals of about every 15 minutes using the DeLay-Hillis fetoscope. So you'll find images of this fetoscope on the subsequent slides, or you can also find this in your book. There is also the Pinard stethoscope, or a Doppler ultrasound device can be used to assess the fetal heart rate. Prior to performing a fetal assessment with this technique, the nurse might have to perform a Leopold's maneuver to determine the fetal position by palpating the maternal abdomen to identify the fetal presentation and position. And basically, we are trying to find the spine or the back of the fetus. Uterine activity is also assessed by palpation. So by just palpating, we can determine how forcibly or forcibly the uterine contraction is. Once position is determined, the nurse applies an ultrasonic gel to the device if using the Doppler ultrasound, and place listening device over area of maximal intensity and clarity of fetal heart sounds to obtain the clearest or loudest sound, so we can actually determine the heart rate and make it much more easier for the nurse to count. So this location is usually over the fetal back. That's why it's important to perform the Leopold maneuver to see where the back of the fetus is. If using a fetoscope, it must be firmly pressed on the abdomen, or firm pressure may be needed. And you are going to count the maternal radial pulse while listening to the fetal heart rate to differentiate it from the fetal rate. So you will palpate the abdomen for presence or absence of any uterine contractions, and also to count the fetal heart rate between contractions. Count fetal heart rate for at least 30 to 60 seconds after a uterine contraction to identify auscultated baseline rate and then changes which will be an increase or decrease in it. And so whilst you are auscultating the fetal heart rate, you have to auscultate before, during, and after each contraction to identify fetal heart rate during the contraction or as a response to the contraction, and to assess for absence or presence of increases or decreases in the fetal rate. So this is a very complicated technique to use, but in most places where they don't have the electronic fetal monitor, you will have to do this. But in the United States, as I said, the most common one is the fetal electronic version of this. What are the benefits of the intermittent auscultation? It is easy to use and inexpensive, and it's less invasive because you don't have to attach anything to the fetus. It is also often more comfortable for the woman and gives her the freedom of movement, and it does not interfere with other care measures such as ambulation to the bathroom or activity which will be restricted if there was an electronic monitor attached. But it also has some disadvantages because intermittent assessment may be difficult to perform in women who are obese. Also, significant events such as potential compromises or fetal compromises may occur during the time where you are not actually assessing the mother, and so this may not be picked up early enough for prompt intervention. Also, intermittent assessment does not provide a permanent documentation or a visual record of the fetal heart rate, and so cannot be used to address visual patterns of the fetal heart rate variability. And so because you are just listening every once in a while, you don't have a continuous monitor to determine if there are any changes. And this can also vary depending on the expertise of the healthcare provider. So an expert or a nurse with much more experience may be able to do this accurately, whereas a nurse with minimum experience may not be able to do this accurately. For example, the nurse cannot document fetal heart tones as early or late or variable because they cannot really quantify this. So this is an example of the fetoscope. All right. Now let's talk about the electronic version of this. As I said, this is the most common in the US. So this is used for monitoring the fetus, and it's used for about 85% of clients in labor here in the United States. The electronic fetal monitoring allows for the provider to monitor fetal oxygenation continuously, allowing for timely intervention to prevent complications. There are two modes of the electronic monitoring. You have the external monitoring, in which an ultrasound or transducer is used to monitor the fetal heart rate, and a total transducer is used to monitor the uterine contraction, so they all can be graphed alongside each other. The other is internal monitoring, which is invasive and is used only after membranes have ruptured. So see application of the electronic fetal monitor video in NCO. In your NCO, there is a video that I have posted in the content. So this is how the electronic fetal monitor, or the EFM, is attached to the mother. All right. Now, to understand the patterns in fetal heart tones on the electronic heart monitor, let us take a few moments to acquaint ourselves with these terms. The first term we are going to look at is the baseline fetal heart rate. This is the average rate during a 10-minute segment that excludes periodic or episodic changes, periods of marked variability, and segments of the baseline that differ by more than 25 beats per minute. So when we look at the fetal heart monitor, we want to see a consistency with the heart rate remaining at the same level. And once we look at some of the strips, we will actually see what I'm talking about. For example, if the fetal heart rate varies between 130 and 140 beats per minute over a 10-minute period, then we can say that the baseline is recorded at 135 beats per minute, because that is the average between the two. There must be at least 2 minutes of interpretable baseline data in a 10-minute segment of tracing to be able to determine the baseline fetal heart rate. So tachycardia is any baseline fetal heart rate greater than 160 beats per minute, unless this is a preterm infant or fetus, while bradycardia or bradycardia is baseline fetal heart rate less than 110 beats per minute. Remember that the normal fetal heart rate is 120 to 160 beats per minute. The significance of fetal bradycardia or tachycardia is determined by noting the type of variability as well as the presence of accelerations or decelerations. Alright, so let's talk about fetal bradycardia. This may result from atrioventricular dissociation or heart block, structural defects, viral infections, or some medications, such as if the mother is receiving opioids for pain management during the labor. It can also result from fetal heart failure, maternal hypoglycemia, and maternal hypothermia. And we are actually going to see this pattern on there. So as we can see, this is below 110. You can see over here that this is 120, this is 110, and so this baseline is around 100. Fetal tachycardia, on the other hand, can be caused by early fetal hypoxemia. So tachycardia may indicate that the fetus lacks some oxygen. So as you can see, or as you remember from perfusion and oxygenation, anytime oxygenation is compromised, the heart will try to beat faster to pump more blood. And that same thing happens in the fetus when the heart, when there is reduced oxygen in the blood for the fetus heart will start to pump faster, and that's what results in tachycardia. There can also be fetal cardiac arrhythmias that can be indicative, or that this tachycardia can indicate. And then if the mother has a fever, the fetus is also going to have tachycardia. And as we know, fever can be a sign of infection. So an infection that can occur in the uterine environment will be chorioamnionitis, which we have talked about. There can also be parasympatholytic drugs such as atropine or hydroxyzine that can increase the fetal heart rate. For example, if the mother's perfusion becomes impaired during the use of medications such as magnesium sulfate to prevent preterm labor, or even the use of opioids, sometimes we will have to give a sympatholytic or parasympatholytic to boost perfusion, and most of the time hydroxyzine or atropine is used, and this can cause fetal tachycardia because the mother's heart rate is also going to increase. Okay. The use of terbutaline can also cause an increase in heart rate in the fetus, And also, if the mother has hyperthyroidism, which we talked about as one of the complications of pregnancy, then the fetus is going to experience tachycardia. If the fetus also has anemia, which will cause a decrease in the amount of red blood cells and oxygen available, then that can also cause tachycardia. In addition to all these, drugs such as caffeine, cocaine, and methamphetamines can also cause an increase in the heart rate, causing tachycardia. Nursing care, if this trace is seen, is dependent on the cause. So if there is maternal fever, then you will have to give an antipyretic to reduce the fever. If there is fever, you can also put in place like cooling measures, such as providing a cooling blanket. And then at all times, you are going to hyperoxygenate the mother, and you are going to use a non-breather mask at 10 liters per minute. And this will help to resolve the issue. So if this is being caused by any medication, then you have to give a reversal of that medication also, and reposition the mother as well. Now let's talk about variability. So we understand what is bradycardia, what is tachycardia. So we also understand what a baseline fetal heart rate is. Let's consider what variability is. Variability of the fetal heart rate corresponds to fetal heart activity and may indicate whether the fetus is healthy or is in distress or not. So variability is the rise and fall or irregular waves or fluctuations in the baseline fetal heart rate. And this may occur per every 2 cycles per minute. It is quantified in beats per minute and is measured from the peak to the trough of a single cycle. And there can be 4 possible categories. So we have absent, which means that there is a monotone, there is no rise and fall in the baseline. We have minimal, which may be slightly or slight elevations, moderate and marked, and we are going to talk about each one of these. So to help you understand these, I want you to compare this to an EKG. Alright? Absent variability looks like a systole. So you basically have a flat line. There are no up and downs. Okay? Absent or minimal variability may indicate fetal inactivity resulting from fetal hypoxia. So just imagine if your patient has a systole, basically it means that they have fainted or they are in some form of coma or shock. Okay? The same thing can be attributed to a fetus that has absent variability, because they may not be moving and so they may be compromised. Minimal variability can also result from CNS depressant medications, including analgesics such as narcotics, as we talked about, meperidine, Demerol, morphine, Dilaudid, and then barbiturates, and general anesthesia. If the mother is undergoing general anesthesia, for example, for a C-section, occasionally you may see minimal variability when the fetus is sleeping also, but should not last over 30 minutes. So if I see a consistent straight line for more than 30 minutes, then it means that the fetus is in trouble. Okay. The nursing action related to this is changing the position or rubbing the fundus to cause the fetus to react. If the fetus reacts, there is going to be variability and we will know the fetus is okay. If the fetus does not react, then there is a problem and we have to intervene. Then we have moderate variability, and this looks like sea ripples. This is where you want the fetus to be enjoying the sea breeze, so think about the sea breeze when you think about moderate variability, because that's where you want to be on vacation. Moderate variability indicates the fetal heart rate regulation is not affected adversely by fetal sleep cycles, tachycardia, prematurity, congenital anomalies, pre-existing neurologic injury, or any other thing that may be going on. And so this means that the fetus is good. And if you see this, you don't do anything, because this is what you actually want to see. Then you have marked variability, and this looks like an A flatter because it looks like that sawtooth. Okay. It is not clear how this is related to fetal compromise. However, changing the mother's position and looking at other indicators may be necessary. So you are looking at indicators to see, is maternal oxygen okay? Is the contractions okay? Is the uterus having enough time to relax? And so by looking at these other things, you may be able to determine if there's something wrong or not. Then you have sinusoidal. Sorry about that. You have sinusoidal, and this is a regular, smooth, undulating wave-like pattern. It is not included in the definition of fetal heart rate variability because it is not common. However, this is linked with severe fetal anemia or infections such as sepsis. So think about fetal compromise that we talked about during labor, during the gestational complications, that if there is sepsis as a result of an intrauterine infection such as after amniocentesis or chorionic villus sampling, then this baby is going to have a sinusoidal pattern. Then we have periodic and episodic changes that can occur in the fetal heart rate. And one of these is known as accelerations. Acceleration of the fetal heart rate is defined as a visually apparent abrupt onset to peak less than 30 seconds increase in the fetal heart rate above the baseline rate, and it's associated with the spontaneous fetal movement. If accelerations do not occur spontaneously, they can be elicited by fetal scalp or vibroacoustic stimulation. Remember when we talked about the non-stress test and the stress test, we talked about the vibroacoustic stimulation, such as by playing music, rubbing the fundus, or using the machine to actually elicit that response. Acceleration is good. Okay, so these are one of the signs that when you see on the monitor, you know the baby is in good health. It's indicative of the fetus well-being because it's responding appropriately to changing environment. Deceleration, on the other hand, is an abrupt decrease in the heart rate below the baseline. So if the baseline is 120, if it decreases to 90, which will be 30 or more than 25 beats, then there is a problem. Deceleration are categorized as early, late, variable, or prolonged, and they are described by their visual relation to the onset and end of the contraction and by their shape, and we're going to talk about each of them. So know that moderate variability is where you want the fetus to be. Acceleration is good, you have to go faster. Being slow is bad for you, and so you don't want decelerations. All right, example of an acceleration is found in the top strip, and this, as I said, represent fetal heart rate, and the bottom strip represents the uterine contraction. So from now on, when we look at the strips, we are going to see one for the fetus, which will be the fetal heart rate, and then the bottom one is always going to represent contractions, and we are going to look at the peak and the trough of each of these. So the first pattern that we are going to talk about is early decelerations. Okay, sorry once again. So the first thing we are going to talk about is early decelerations. And early decelerations is a gradual onset or decrease in and return to baseline of the fetal heart rate with uterine contraction. And onset is to the lowest point where it is equal to or greater than 30 seconds. The onset and recovery of the deceleration corresponds to the beginning, which is the peak, and the end of the contraction. It's usually the mirror image of your contractions. So if you look at your screen, if you look at where the arrow is, you will see that the peak of the contraction and the trough of the fetal heart rate mimic each other. That is the mirror image. This is what we call early deceleration. Early deceleration occurs with fetal head compression. So as the mother tries to push and the fetal head becomes crowned and engaged in the pelvis, the compression causes that early deceleration. And so nursing intervention is not needed at this time because early decelerations are considered benign and does not pose any harm to the fetus. The heart rate usually returns to normal after the end of the contraction. So once again, early decelerations starts at the onset of contraction and ends at the end of the contraction, and is the mirror image of the contraction, and you don't have to do anything because this is not harmful to the fetus. Then we have late deceleration. Late deceleration of the fetal heart rate is a visually apparent gradual decrease in and return to baseline of the fetal heart rate, and there must be a decrease to the lowest point, which is equal to or greater than 30 seconds. And this is associated with uterine contractions. The deceleration begins after the contraction has started. So when you look at the peak of the contraction, like when you look at the curve of the contraction, you see that the heart rate descends after the peak of that contraction. Okay, that is very important. That is the marker of late deceleration. Late deceleration indicates reduced blood flow and oxygen supply to the fetus, and this may be caused by conditions such as maternal hypotension, preeclampsia, post-date or post-term pregnancy, when there is an infection such as amnionitis, small for gestational age fetuses, maternal diabetes, placenta previa, placenta abruption, conduction anesthetics, which all may decrease the amount of oxygen to the fetus. So any condition that is going to reduce the amount of circulation and oxygen can cause late deceleration. The most common cause, however, is uterine tachycystole, which means that there is no relaxations between the contractions, okay, and so the contractions are occurring much more frequently than we want it to be. So think about nursing interventions, especially when oxytocin is being used to augment labor. That's why you have to assess frequently to make sure that there are no complications going on. Your actions as a nurse should focus on increasing placental blood flow and resolving underlying problems. So for example, we may have to change the maternal position. Remember that there can be hypotension as a result of the mother laying on the portal vein, laying on the back. Okay, so you want to prevent that. Then correct maternal hypotension by elevating the legs. So lift the legs up and also increase the rate of maintenance intravenous fluid. However, if there is oxytocin mixed with that fluid, because you want to decrease the frequency of contractions, you are going to hang a new bag of D5 saline or normal saline. You are not going to increase the rate in that oxytocin, because remember, oxytocin is used to increase contractility. You are also going to palpate the uterus to assess for tachycystole, or look at the pattern to assess for tachycystole, and administer oxygen 8 to 10 liters per minute via a non-rebreather mask to increase the amount of oxygen to the baby. And once all these have been done, or while these are being done, you also have to notify the primary care provider to be around just in case a C-section is indicated. So after these have been done, then you will also have to consider internal monitoring for more accurate fetal and uterine assessment, and then assist with obtaining consent and prepping the patient if a cesarean or vaginal assisted birth is indicated. The third piece in decelerations are variable decelerations. This is an abrupt or apparent decrease in the fetal heart rate at least 15 beats per minute or more below the baseline, lasting at least for 15 seconds and returning to the baseline in less than 2 minutes from the time of onset. So causes of variable decelerations include cord compression, such as when the fetus wraps the cord around his or her neck, or if it wraps it around the arm, leg, or any other body parts. And then if the cord is made short by the frequent movement of the fetus, or if there is a knot in the cord, because sometimes they move around and then the cord gets twisted and gets tied. This can also be as a result of cord prolapse, where the cord is actually protruding from the cervix. So let's look at what you are going to do as a nurse when you see this strip, which is variable deceleration. The usual priority interventions are as follows. First of all, you are going to change the maternal position, and the preferred position is to put them in a side to side lying position, or put them to the knee to chest position where they are kind of scooped over. Then you are going to discontinue oxytocin if it is infusing. Administer oxygen 8 to 10 liters per minute by a non-rebreather mask, and then notify the primary care provider. And then you are going to assist with vaginal or speculum examination to assess for the cord prolapse. If there is a cord protruding, then you are going to insert a sterile gloved hand or finger in there and push the baby's head up. And you are going to hold that position to keep the baby's head from compressing the cord until delivery has been achieved, whether by cesarean birth, which is the most common form of birth if there is a cord compression, because you don't want to cause further fetal distress. And then you are going to assist with amnio infusion as ordered if there is no cord protrusion and if there is just a compression, and then assist with birth as indicated. So these are the steps that you are going to take with variable deceleration. If there are prolonged deceleration, this can be caused when the mechanisms responsible for late or variable deceleration last for an extended period of time. So prolonged deceleration is an elongated form of late decels or variable decels. Okay, and this may be lasting for more than 2 minutes. Remember, we said in variable decels it shouldn't last more than 2 minutes, but for prolonged deceleration is going to last for more than 2 minutes. Examples of conditions that can cause an interruption in the fetal oxygen supply long enough to produce a prolonged deceleration include maternal hypotension, such as if the mother is receiving, once again, opioids or anesthesia, or if the mother is losing blood, such as by if there is placenta abruption during the labor process, or if there are any other causes that is causing the mother to lose blood. Uterine tachycysto, which is the frequent contraction of the uterus, can also result in prolonged decelerations. Also, if there is a uterine rupture, which sometimes is possible, this is a tear in the wall of the uterus. This can also cause prolonged deceleration. Extreme placental insufficiency and prolonged cord compression or prolapsed cord can also cause prolonged deceleration. And with this, delivery of the baby through C-section is imminent if you see this. The intervention for this is similar to the ones for late and variable decelerations, and then you will also have to obtain a consent from family to do a cesarean birth or to assist in cesarean birth. Now let's look at some general care and management of the client who is going through labor and having any of these fetal heart rate patterns. You are going to perform basic interventions such as administering oxygen by non-rebreather face mask at a rate between 8 to 10 liters per minute for approximately 15 to 30 minutes, and then assist the woman to the sideline or lateral position. Increase maternal blood volume by increasing expansion fluids such as normal saline or D5 with saline. And then other interventions specific to the problem that is causing the deceleration is for you to correct that. So this includes maternal hypotension. If the mother has hypotension, then you are going to increase the rate of primary IV infusion, change to lateral or Trendelenburg position to increase perfusion, and then administer ephedrine or phenylephrine if other measures are unsuccessful in increasing the maternal blood pressure related to pain medication or anesthesia. If there is uterine tachycysto, Then reduce or discontinue the dose of any uterine stimulants in use, such as Pitocin, or also known as oxytocin. Then administer a uterine relaxant such as a tocolytic. We talked about tebutalin, which is used to prevent preterm labor, and give it either subcutaneous or IV. Then educate the mother about side effects of the drug, such as heart racing. When you give tebutalin, she's also going to have or experience skin flashing and tremors and restlessness as a result of the giving of the tebutalin. It is contraindicated if the woman has heart conditions such as hypertension. So if they have preeclampsia or eclampsia, you cannot give tebutalin because of its increased effect on the heart rate. And then if they have hyperthyroidism and uncontrolled diabetes, it is also not recommended for you to give tebutalin. If there are abnormal fetal heart rate patterns during the second stage of labor, then you are going to use the open glottis or spontaneous pushing method to decrease pain by teaching the mother to push when she is ready and avoid holding her breath. Because when she holds her breath, she's not breathing in oxygen, and if she's not breathing in oxygen, then the fetus is not getting oxygen. So use fewer pushing efforts when you are doing this during each contraction, and make individual pushing very effective. So you are going to push with the contraction only, and push with the feeling of pressure. Like if the mother is feeling the pressure, then she should push. If pressure is perceived, if there is the use of local or regional anesthesia, such as when you have your epidural. Okay. All right. So thank you for listening to this presentation. You are going to find the answer of this question when we come to class. So fetal tachycardia is most common during, and then choose one of these answers, and we'll talk about it when we get to class. And once again, thank you. Make sure you do all the readings and you review the other materials in this module, and we will do some activities in class to help you understand and apply the fetal heart monitoring that we have discussed. If you have any questions, just email me, and I will be more than happy to address your questions in an email or during class. Take care.